kids used to try and escape to school without brushing their teeth in the morning. They don't have to buy anything new. It's not expensive. The cheapest bloody fluoride toothpaste at the supermarket is probably just as good as the most expensive, despite the advertising. Twice a day. And we know that you get about 25% more reduction in caries if you use it twice a day compared to once a day, because you load it up again. You get the fluoride in the system. So it's a lovely paper that shows that it's not, in my mind it used to be getting the fluoride in the enamel was the most important thing. It's not. It's getting it at the surface, because it makes it easier to maintain saturation. It's limited by the amount of calcium and phosphate when you're thinking of remineralisation, so sticking stuff back in to the tooth. And I don't know how many of you know how much calcium and phosphate's in your saliva. Phosphate's reasonably abundant in the mouth. Calcium's the limiter. You might have 1 or 2 millimole. Some people might have 5 millimolar calcium. So there's not a lot of calcium around. It's quite limited. And some of it's bound up in some of those peptides. And where can you get it from? Saliva, a little bit in gingival crevicular fluid. And now there are a whole lot of systems commercially available that propose that they provide calcium that can be available for remineralisation of teeth. The problem that we've always had, sticking calcium in toothpaste, what happens? If there's fluoride in there, you get calcium fluoride. The other way of getting around that is use, pardon me, sodium monofluorophosphate, and the fluoride's bound to that phosphate really tightly. And so you can use basic calcium carbonate as an abrasive in those products, but the minute the fluoride comes off that phosphate, you'll get calcium fluoride formed. So it's a limitation, and it's why there haven't been free forms of calcium available in toothpastes, because they bind with the fluoride. And once you do that, your fluoride level goes down. It's basically crunchy toothpaste. So a number of different systems around the calcium phosphosilica class is Novamin. So that's the stuff in Sensodyne. It was a separate company, and then GSK bought it a couple of years ago. Functionalised tricalcium phosphate is Clinpro, toothpaste, varnish, TCP, they call it. Medical hydroxyapatite's in a Voco product, the Remin Pro. Why you'd put something incredibly insoluble into a paste and then sell it to people, I don't know. Why don't your teeth just fall to pieces? Because they're made of hydroxyapatite. Do they think that's going to dissolve in your mouth? I mean, I met the guy who invented it and he's still bewildered. The amorphous calcium phosphate you'll often find in bleaches. So ACP pops up, and it's in some varnish. Premier make a fluoride, 22,600 fluoride varnish with ACP. And then the systems I've been involved with, the stabilised systems. So it's calcium and phosphate stabilised by a little milk protein. So it's a casein-based system, and what our group has done, or my boss's group has done, has worked out which part of the casein actually does the calcium and phosphate stabilising. And there's an evolutionary pressure for milk to be a good calcium phosphate stabiliser, because it gets your kids' bones to be healthier and grow quicker. So that's why these proteins exist. Lots of products, and more as each day goes on. So CPB ACP. There we go, okay. Basically, it's a clump of calcium and phosphate stabilised by these little peptides. And the mechanism is quite simple. Let's see if it runs. It's not going to do it for us, is it? No, that was a little video of it. Basically, calcium phosphate, when they're in solution, especially at or around saturation, clump together. Once you get to supersaturation, they clump together and get to a size that then precipitates precipitation or crystallisation. What these little peptides do is stop it getting to that level. So these little bits of protein clump around these small balls of calcium and phosphate, and they're tiny. They're 2 nanometres, a bit less. So they're very small. When you think a rod of enamel is 6 microns, 7 microns. So they're tiny. But it stops them getting to the size where they start precipitating out. So it's a simple mechanism of stopping the clumping, getting to a big part that starts crystallisation. See if we can get past this. You find it also changes plaque characteristics. It binds into plaque quite happily. And the little black dots are the casein phosphopeptides. And as someone who clinically used tooth mousse for a long time, long before I actually started work on it, you knew the kids who were using it because their plaque looked different. It was thinner and less fluffy, if that's I don't know, when you look at kids' teeth, some look like they've got ricotta cheese on their teeth. Well, there wasn't much ricotta going around. So it does change, and we've done more research recently on biofilm changing characteristics. Some work done in the UK, in Bristol by Keith Rose. You get a toxic effect if you've got high levels of calcium and phosphate, apart from the binding effect, changing the interactions between the bacteria and the biofilm as well. And a Greek group looked at adhesion, and if you actually get the peptides binding, the CPP peptides binding to the tooth surface, it inhibits biofilm formation because they take up some of the initial binding sites. So you get less biofilm formed. And when you look, this is some of Stewie Dashper's work just looking at the effect on biofilm, and it's the same image just with a black and a white background because some people like one or the other. You get a decrease in plaque bulk if you flow this CPP ACP over the plaque. There are some other peptides, which is another day's talk, from milk that actually have an anti-biofilm effect, nearly like an anti-fouling effect. But it seems to be an interesting one that it seems to make the bugs want to jump out of the biofilm. So it doesn't kill them. There's not a lot of cidal effect on the bacteria, but there's quite a large effect on which bugs are in the biofilm, and it makes the biofilm reasonably uncomfortable for them, we think. So I'm just about to start another PhD student looking at that in the next 12 months. It binds into the mouth quite nicely and hangs around a lot longer than fluoride does. So you can pick up the peptides up to 3 hours after and this is chewing one bit of gum, so it does hang around. Is there any evidence? And I've cut this bit down. You have to trust me on this one. This is some of my work, looking at different types of chewing gum. The percentage R, so the last column is the one. That's the amount of remineralisation you get. So this is an in situ study. You think the white spot lesion we put into the mouth is 100, negative 100. This is how much we put back into that negative 100. So Orbit gums, a sorbitol-based gum, Orbit Professional xylitol-based, and Trident White is a CPP with xylitol, maltitol and sorbitol. But you can see you get nearly twice the remineralisation because you're pumping a lot of calcium and phosphate into the system. And it's stabilised calcium and phosphate. So it's not coming out bound up as a crystal. It's available for remineralisation. And that's the little appliance we use. You see the mouse is in, with the little slabs of enamel with white spots in them. And these, you think of these like reading bite wings. These are microradiographs, surface, about 90 microns here, sound enamel here. And like bite wings, the whiter it is, the more mineral there is. And then we run these through computer programs and quantify how much mineral's there. As a kid's dentist, making sweets that actually are beneficial for your teeth rather than deleterious to your teeth is obviously the holy grail, and I'm a great sweet eater, especially after a few beers. When you put a bit of the CPP into a show, these are like boiled sweets we used, and this was leaving that little ortho appliance in there for 24 hours a day, and they sucked them 7 times a day. When you add 1% of CPP ACP, you actually get a gain of 10% mineral. So it's still a sugared sweet. It's just that there's enough calcium and phosphate to balance out the loss that you get from the acid decrease. So it's maintaining saturation. You still get an acid decrease, but because of supersaturation, you actually end up with a net remineralisation of the lesion. It's better if it's sugar-free because you don't get the acid decrease. But it shows that it's not just pH. You're still getting the pH drop there. It's the calcium and the phosphate. No one's made it commercially, unfortunately. We did a big trial, probably the biggest caries trial done in the Southern Hemisphere in the last 50 years. And we looked at nearly 3,000 kids, chewed gum for 2 years. Hugely expensive, $6-7 million bucks. From memory, we used bite wings, standardised bite wings. We analysed them. I was the gold standard for the bite wing analysis, and we basically had little drop-down boxes, and we had baseline and endpoint, and had a score for each surface, and then looked at the differences. And after it was ended up nearly 5 years of work, when you looked at the results, you got significantly more regressions of the lesions and significantly fewer progressions in the active group. So the group that actually chewed recaldent gum compared to the control gum. And it was totally blinded. It came in little silver packets and no one knew until we broke the code after analysis. So in a clinical trial, and we didn't have a true control, because you know that chewing sugar-free gum is good for your teeth, you get fewer lesions. We weren't allowed to have kids who didn't chew gum, because you've just told the ethics committee that chewing gum's really good for their teeth, then it's unethical to not give it to everyone in the trial. So it would have been interesting to see what the true control was, how much caries they got. But unfortunately, there are limitations of clinical trials. So tooth mousse, we did some trials just looking at post-orthodontic white spots. There's the person who is actually responsible for orthodontics in my school. Some of my colleagues tell me they've never seen a white spot lesion, which means either the teeth are covered in plaque or they've never looked. This is our friend Bjorn Ogard again. He said up to 60% of ortho patients can get white spots. There's other evidence that would suggest up to 90% of ortho patients get white spots. We just looked at a small study, 45 kids with 400 lesions. They applied tooth mousse or a placebo cream, and then we looked at 1 month, 2 months, 3 months down the track. When we looked at 3 months, the tooth mousse group had 31% lesions that regressed compared to the control group. But the interesting thing was that the ones that were graded active remineralised much better. So when you look at the odds ratio, it's 2.3, so that's 2.3 times more chance of getting remin if you use the tooth mousse compared to the control. If they're active lesions, it's 5 times. And it's because the surface is open. It's like a colander, it just allows everything through. And so they're the last teeth you should ever put fluoride varnish on, or 5,000 ppm, because you give it a really good surface layer, but leave the body of the lesion, so they look like shiny white spots, and they're really hard to remineralise. So if you've got these kids with really active lesions around brackets, you don't want high fluoride concentration. They're better off with spit. But the last thing you should ever do is put varnish on them, because you'll get hypomineralised surface layer and they don't like white spots, and then you'll get people trying to sell them veneers. And we used QLF, one of my postgrads is actually analysing this data now. This is, when we talk about early diagnosis, this is a technique that actually quantifies the white spot for you and gives you some numbers, and then you can compare them longitudinally. The trouble is, this unit was €50,000, which isn't much now. It was a hell of a lot then when I bought it. So no one's going to put that in their surgery. But not bad for research. When you look at the product, the amount of calcium and phosphate in some of these commercial products, you'll see that there are marked differences. So these Tooth Mousse Plus, 1000 toothpaste, Nutrifluor, ClinPro, which is the TCP one, and then a placebo tooth mousse. And you'll see the amount of, and it's the calcium we're really interested in, you'll see the amount of calcium comparatively. And this is total calcium. So basically what you want is a product that has a huge amount of calcium that's available. And people bandy around bioavailable, but that's really what you want. It's fine to have an enormous amount of calcium in the product, but if it's all bound up in crystals, it's useless. You're just spitting it out or swallowing it. So you can see that the CPP certainly allows us to load up these products with calcium. Yeah, and when we look at remineralisation, similar sort of protocol, plate in the mouth, 2 weeks, using it 3 times a day. But when you look at the 5,000, see how you get this quite intense surface layer? And even with the ClinPro. But you can certainly see the difference in the darkness. And the interesting thing, because the CPP controls the amount of calcium and phosphate released, you actually get remin down to the depth of the lesion. So it's quite unusual in that sense that it doesn't seem to be a surface downwards remin. You get reasonably even remineralisation through it, and this is in 2 weeks. And when you look at the remineralisation amount, you can just see as it goes up. What we were surprised with was how little the Nutrifluor 5000 gave us. We thought that would be much higher, and after many sessions in the pub trying to work it out, we thought it was actually saliva limitation. So there's so much fluoride, it uses up all the calcium and phosphate out of your spit. And so the 5,000 is probably a bit of a waste. You could probably have 2,800 and get a similar amount of remin, because there's more fluoride than you actually can utilise. So, you know, a product with 5,000 and a bit extra calcium and phosphate would probably be a real kick-ass product. We've stuck it in Fuji 7. There's not a lot of evidence around this. We use it because I can't see the downside, but there's certainly not a lot of published evidence around improved remineralisation at the margins. There's one paper from our group that showed, when you look, these are, that's composite, glass ionomer cement, put in a demineralised solution, and then you look at the white spot lesion development. And the more CPP you get, the less demineralisation you get at the margin. So there's some lab studies, but I don't know any clinical studies as yet. We've done some work just looking, using confocal microscopy, just looking at biofilm formation, and you certainly get an inhibition of biofilm formation on the Fuji 7. So you get less biofilm. But again, it's lab study, it's not clinical, so we certainly need some more clinical studies. It's in the product. This is labelled CPP ACP on a fractured piece of Fuji 7, so it's actually reasonably evenly spread. So, summarising, when you're looking at CPP ACP, normally clinically you're thinking, when should I apply it? And we'd normally recommend before they go to bed. If you can get someone to use toothpaste twice a day and another product once, I think you've done as well as you can ever get with compliance with kids. The theory behind the bed idea is salivary flow drops off, so it'll be more persistent overnight, so it's actually in the oral cavity for longer and you get more chance of remin. Is there any research on that? Not that I know of. It just seems a reasonable idea. So how often? We'd normally go once. If it's like one of my mum's friends who just had chemo and radio or something and had no spit at all, told her to use it whenever she could, because you're just trying to maintain some calcium and phosphate. How much? About a pea. With the fluoride, the normal comment would be anyone above 10, you've got to think of a reason not to use the fluoridated product. So the Toothmousse Plus. Under 10, Toothmousse. And it was just I'd actually got asked to do the European guidelines, and it was just an easy number to remember, and it's basically out of fear of fluorosis. And I thought it was a lot nicer to be really safe about fluorosis. You're probably right at 6, but you wouldn't tell a 6-year-old to swallow a gram of toothpaste, and inherently that's what you're doing if you're telling them to swallow a gram of Toothmousse Plus. So we've been reasonably cautious about that. With the antibacterials, we don't know. Chlorhexidine and fluoride aren't very good friends, and so it's probably best to avoid applying fluoridated products with chlorhexidine, but there's not a lot of research that would tell us which way to go with regard to antibacterials. So caries-wise, what do you want to do? You want to get as much calcium phosphate and fluoride in the system as you can. And you want to maintain those levels for as long as you can. If they've got biofilm around, you want it in the biofilm. It's no good if it's in the spit. It needs to be where you get caries. So you want to bind it into the biofilm, and certainly the CPP will bind into biofilm and be far more persistent than fluoride on its own. And I've cut out some research showing about persistence of fluoride in biofilm with and without CPP-ACP. So increasing fluoride in the mouth with children, that's obviously got to be considered with respect to fluorosis as well, so fluoride ingestion. Decreased sugar exposure, especially sucrose. Sucrose seems to be the killer with caries. You get different plaque with sucrose than you do with other sugars. Disturbed biofilm frequently means brush your teeth. Individualise your caries management is the minimal intervention idea of, or Canberra idea of risk assessment and modifying what you tell them depending on their risk. Oh, there, molar hypomineralisation. So I assume you all see these, those of you who treat children. I mean, this is just some of Harlene's. Obviously, these aren't in anyone's mouth, so they're normally the more severe end of the spectrum. These are sitting in the lab somewhere. And it's good to see amalgam, my old friend. But atypical restorations, but these teeth that are often in perfectly healthy mouths, they've never had any deciduous caries, and suddenly these bomb sites erupt. And we see a lot of it. So it's a huge problem for us. Definition-wise, Karen Weirheim and a group came up 10 or so years ago with the definition. Basically, MIH is the term that's been used frequently, and I'll continue to use it here. We've sort of changed it to MH because the incisors aren't a huge issue. It's the molars that are the problems. So we think molar hypomineralisation and molar hypomin is more important than the molar incisor hypomineralisation. But you have to have it in the molars to be part of the spectrum. You can't just have it in the incisors, then you've just got incisor hypomineralisation. So there's molar hypomin, which is just the molars. The thing about diagnosing it correctly is it changes the way you treat these kids totally. It's not caries. It may have caries secondary to it, but your restorative and treatment planning decisions are modified totally if you're diagnosing hypomin, because you can't trust the enamel anymore. So it's something that's really important to get right at the start. It's not hyperplasia. Hyperplasia is thin enamel. Hypomineralisation is normal thickness, less mineral. You can normally bond to hyperplastic enamel quite happily. Bonding to this stuff can sometimes be very problematic. So diagnosis is really important because of that. That it gives you a chance to actually make the right treatment planning decisions that will minimise the treatment load on these kids. And by the time they see us, they're normally destroyed. So we get a lot of very distressed, phobic children because of the problems with these teeth and what people have tried to do to them. So issue-wise, there's less mineral, there's more protein. This is in the enamel. They look different. They're softer and weaker, and there's more carbonated apatite, and carbonated apatite will dissolve a lot quicker than hydroxyapatite and fluorapatite. So they're liable to fall to pieces and dissolve at the same time. So they've got everything going against them. So hyperplasia is thin enamel. And I have great pleasure in failing final years when they tell me they've seen some hyperplastic sixes. So I'm the silent assassin in the Melbourne University Dental School. My colleague is the silent assassin. So, no, I'm the silent, he's the smiling, I can't remember. But this is basic stuff that people still stuff up. When I was an undergrad, we called them hyperplastic sixes because we didn't know what we were talking about. But the enamel is not hyperplastic, it's hypermineralised. That's hyperplasia. Thin enamel, that's a kid who's had some insults, probably at birth and a bit after birth. But totally different to hypermineralised enamel. I can bond to this. and they don't fall to bits. So these are the anterior teeth in that kiddie as well. So we had hyperplasia and teeth forming at the same time. The issue with hypomineralisation is it often occurs atypically and asymmetrically around the mouth. So you'll have a tooth that's just affected, its mate downstairs totally blown out, and perfect one over here. It makes no sense. Whereas hyperplasia, you tend to say, oh, okay, I can really look at kids and tell what age they had the illness at. Doesn't happen with hypomineralisation. It's confusing. So when you're diagnosing, you look for patterns. Kids who've had no caries before and then suddenly they get bombed out sixes. It doesn't make sense. Yeah. So the other thing that I think of the hundreds of thousands of kids I've taken to theatre in the past with bombed out E's, perfect D's, and go, well, this is a funny pattern. Hypomineralisation happens in E's and D's as well. Less frequently, but it's certainly there. So it's something to look out with your young kids. If the pattern of caries is a bit strange, think of hypomineralisation. So the person probably most responsible for the hypomineralised E's is Marley Selfrink from sort of smiling there. And the fantastic, in the Dutch area they call them cheesy molars. So this is the front page of her PhD thesis with a lovely piece of cheese made into a tooth with holes in it, which I thought was good. You'll see these sort of kids once in a while. So this isn't hyperplasia, this is post-eruptive breakdown on a hypomineralised C. And when you see this, take a breath and have a look down the back because it's normally reasonably severe. So you'll often see E's that look like this. And you go, it's a funny caries or it's hyperplastic. It's not. It's enamel that's broken down after the tooth has erupted, and this is in a kid with really low caries risk. In a kid with high caries risk, these are roots with a nice little abscess on the side. So it can happen in young children as well. But the insult will be earlier. It will be around birth or before birth. We did, with Felicity Crombie and Nikki Kilpatrick, some work looking at etiological factors. There are hundreds of etiological factors that have been put up. There aren't any that are flagged that are the real ones. It's probably multifactorial with a bit of genetic environment in there as well. But it certainly is increased in prevalence in sick children. So illness has got something to do with it. Prevalence is all over the place. The 2% was Hong Kong. It was probably not a great study. The 40% was a specific population in Brazil. Here in Perth, it's 22. There's no other studies I know about of a representative population in Australia. We're just about to start one in little kids to look at E's in Melbourne. Study just come out of Singapore. I got the data yesterday. Traditionally, we've always said Asian kids don't get it very much. This Singaporean study looked at Malays, Chinese Singaporeans and subcontinental background Singaporeans, and the Chinese Singaporeans had a much lower level or much lower prevalence than the Malays and the mostly Indian population there. So there's something going on. Is that dietary? Is it illness? We don't know. But there was certainly differential in prevalence. But it was about 10% in the Asian population, whereas in Singapore we thought it was a lot less. What are the issues? They fall to bits and become caries. They don't etch.